Hi, welcome to our conversation today with Dr. Walavan Sivakumar. My name is Laura Dennis. I'm the Senior Vice President of Sales and Marketing here at Zoran Technologies, and we're here to talk today about the xCAT IQ. Everything is reversed for me. So thank you so much for joining us here in the middle of your very busy day. I really appreciate it. Dr. Sivakumar is the Director of Neurovascular Surgery at the Pacific Neuroscience Institute over there in sunny California. Well, I heard it was raining, and has been using Zoran's xCAT IQ for almost a year. And I'm here to talk to him today about what that experience has been like. And so we're super excited to have you.
Yeah, no, happy to join you here.
So maybe you could just start by telling us a little bit about how you've been using xCAT IQ and what your vision is for future expansions of the device because of its mobility.
Sure. It's been a very exciting transition, and when it came up from a need that we had with our own operative care protocol in terms of the desire for confirmation that we'd achieved the goals of surgery. So that was when we first started doing this. Historically, every one of our patients, before they after leaving the operating room and before they went to the ICU or anywhere else, we typically do a CT scan to make sure there's no intraoperative complications. And that process, although it sounds easy, was pretty cumbersome. It requires transfer with the anesthesiologist, the operating room nurses, an assistant, sometimes respiratory therapy when they had to carry a ventilator, going across floors in the hospital to the CT scanner down in the basement. And that may not seem like a big deal, but a transport of a critically ill neurosurgical patient is very involved, and it carries with it a fair amount of risk, not to mention the amount of time that it takes to set everything up on top of the original transfer. So I've been finding ways, or trying to find ways, to optimize that process for several years now. And then when I ran into Michael Walker and we started talking about this technology, it really opened up the potential for what I was looking for. I was looking for a portable device that could be brought into relatively small spaces, and one that would have a relatively high level of precision with a rapid turnover time that's also safe. A lot of the portable scanners that are out there, they take up a very large footprint. It's hard to maneuver them. I've had several years of experience with a lot of different good ones out there on the market, but actually getting a patient scanned was quite a bit of a process. This device, without it being a closed arm, able to mobilize around the patient and fit into relatively small places and have a really tight footprint, seemed especially attractive. So we ended up taking it and starting in the operating room for that post-operative confirmation. And since we started doing that, it's been taking a larger and larger role in our flow.
Thank you. And then the scan is relatively quick, less than a minute.
In the time that we started using it at the beginning, it was impressive with how little time it took at that time to right now. It's just continued to get more and more efficient. Historically, taking a patient down to the scanner after a case and then having it finished and bringing him back up, that would take upwards of 25, 30 minutes, sometimes even longer than that. Now, when we're finishing up a case, my OR nurse calls the CT technologist, and then they come up and they do the scan, and we can get the whole process sometimes done in about 5 minutes, which is pretty incredible.
Pretty amazing. Yes.
Yeah.
So what types of procedures has this been most impactful for you from a clinical standpoint?
As we've optimized the process and gotten used to the technology, it's starting to have a use in all cranial surgery, essentially. So before, I was starting with just tumor resections, but we've subsequently moved on to ventriculoperitoneal shunts, all of the tumor resections, both in the supratentorial and the infratentorial space, or the posterior fossa. I just completed a case this morning doing a microvascular decompression, and having that scan has allowed us to accelerate our patient's care plan as part of our enhanced recovery program.
And the image quality is what you're looking for to make those decisions about the
Yeah.
kid post-surgery?
That's been one of the limitations with a lot of the different machines. The technology that's in the xCAT IQ is actually quite impressive, and it seems to be improving with the different updates, and it gives you the amount of information that you need to make that judgment call of, did we achieve what we needed to do? Is this patient safe? And in particular to what I'm doing after a tumor resection, if the case went well, I don't see any evidence of any immediate postoperative complications. It allows me to downgrade patients to suddenly not needing the ICU. So
Wow.
taking a patient right after a brain tumor, for example, actually the majority of my elective cases now go to the step down unit and not the ICU. And I wouldn't have the comfort to do that without the knowledge that intracranially everything looked good. And that kind of information I get through the xCAT IQ.
That's extremely powerful to point to drive home, especially
Absolutely.
since we're hearing about nursing shortages, the impact of when you have one nurse even leave the ICU in order to transport a patient, let alone be involved in a patient transport while you're keeping the OR open. So that's extremely impactful to hear. And I know you also have some future plans for how you want to expand your use of xCAT IQ in the hospital.
Absolutely. I think that point you made was a very, very important one, because that's where this entire need started. The desire to decrease the care provider burden, separate from the surgeon. And it's accelerated. We've used this well over 100 times now. And as the workflow has been completed, the entire staff have become more and more comfortable with it. Now we're using it in all of these cranial cases in the operating room. Our plan is to take this into the ICU next. There are a lot of patients in the neurocritical care service at our neurocritical care unit where, when there's a change in the patient's neurological exam, getting him packed up and transported down to the ICU actually has more risk than even these patients in the operating room. So once we're able to get these patients for that confirmation, one, there's no new bleeding. One, a bleed hasn't gotten worse. One, there's not another issue that we weren't expecting. That provides a tremendous amount of value with it. And after the ICU, it's been so well received in the hospital. If we can show the same concept in the ICU that we did in the OR, we'll probably move it to other floors as well, because it's so mobile, potentially even the emergency room, where there's an extra level of, hectic activity going on, where anytime you can decrease one step, it's going to help the patient's workflow and safety.
Thank you so much. And just a quick question about radiation dose. I mean, we, of course, here at Zoran, we know that we always optimize all of our doses according to the ALAR principle, as low as reasonably achievable. But what has been your experience in terms of workflow and patient? It seems like the value to the patient and the care, it has made any questions about radiation dose not really come to the forefront.
Yeah. When we were bringing this technology out and using it, the safety was the main factor, of course. And you guys have shown, I think you guys have done a very good job of showing, because of the different processing that you guys are doing, you're able to minimize the dose to a very large degree, more so than I think any of the other units out on the market. And because of that, we do this in conjunction with our radiation technologists in the radiology department. I took a lot of their input early on, and I was surprised actually at how comfortable they were, and continue to be using the device on those grounds.
Exactly. And once you've have the buy-in and the peace of mind of the dose, it makes it so much easier to just wheel it into a regular elevator, take it down, and expand the use throughout the hospital. Is there any other comments or anything else that you would like to share with us today? This has been such a fascinating conversation.
No, I think we've talked on the salient points here. I think the opportunity to accelerate a patient's care with any of the technologies makes this very, very useful. And I'm excited to have been one of the early users of the device. And I'm excited to see, as the technology improves, as the workflows become established, I think there's just going to be wider and wider, and should be wider and wider adoption of this unit, because surgeons, our charge is to think about the patient in their totality. And oftentimes it's hard to think about them outside of where you're directly with them, and when you think about the fact that you're responsible for their entire process and everything that happens around them, these small things like patient transport take on much, much bigger meaning. And anything that helps that and makes it safer is going to make your life better and easier, and just make the entire flow much more advantageous to the patient.
And peace of mind for the surgeon as well. Like you
Definitely,
said.
yes, peace of mind is invaluable. Yeah.
Yes. We sometimes forget about that, but I do appreciate what that can do for the whole experience for everyone involved. Well, thank you so much for your time today. I really appreciate it. This is a wonderful interview, and we look forward to speaking to you again sometime in the future.
Absolutely. Yeah.
Thank you.
Looking forward to it. Have a good day.
Thank you.